Welcome back, everyone. Today, I have someone who is incredibly well reputed in the field of laboratory medicine and is a doctor who has done a fellowship in pathology and is the head of Suburban Diagnostics. He started his journey in 1994 and was educated in Mumbai at some of the most prestigious places, and then went to the US to finish his journey at Tata Memorial and as well as a whole host of other very, very prominent organizations, and then came back to India to start one of the first diagnostic chains in 1994 called Suburban Diagnostics. Welcome to the channel, Dr. Arora, and thank you so much for joining us.
Thank you so much for inviting me today, Dr. Nene. Thank you.
It's my pleasure. We wanted to talk to you a little bit about the journey in the last year. And I would say if anyone is close to what's going on, you would be it. I mean, it started in March of last year in India. And I can remember back then, there was a lot of anxiety in the public's eye, but even in the doctor's camp, it was very hard for us to know. Tell me your thoughts, because this was what they call a novel coronavirus. How did that affect you in the lab? What did you have to do to kind of retask and get everything going?
No, thank you. Thank you so much for asking that question. So it takes me back to February last year when we did realize that it's not merely an infection that's going to be affecting China or other parts of the world, but it's going to come to India as well. And it had come to India by that time. So we started thinking about how can we contribute, how can we become relevant, how can we make a difference. So earlier part of March last year is when we started doing research on what kind of testing kits are available, whether we have the right infrastructure to be able to support that. And we started, chatting with authorities to see how do we become eligible for testing. On 22nd of March last year, that's 22nd of March 2020, we were given the opportunity to become the first lab in the country who was permitted to test for coronavirus or COVID-19. And we did our first test on 24th of March 2020. And why I remember that date, it will always remember because it will always remain with me. It happens to be my birthday. And, my team, told me that I don't think we can give you a better gift than the opportunity to test. We did our first test on 24th of March last year. And as we know in life that, there are 2 days that are important, the day you were born and the day you realize why you were born. And last year on my birthday, I realized that I was born, to be given an opportunity to add value to mankind, to be able to contribute, to be able to make a difference. And that's what gives me the maximum happiness, is to be able to contribute and truly make a difference over the last 14, 15 months that we've been testing for this, for this condition. Yeah.
I mean, that sums it up. I think COVID has been about heroes, and like any wartime activity, it's not the soldiers this time. The soldiers were the frontline workers and the doctors and the nurses and even the government frontline workers and whatnot. And so many of them gave up their lives to do what they did. Did this affect your organization at all?
Oh, absolutely. 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 I think, as you said right in the beginning, that there was so much of chaos, there was so much of anxiety, and there was so much of uncertainty. And we realized that if we have to test for the virus, we have the capabilities within the lab, but finally we need to have people who can go out and collect the sample. So being able to, first convince people within our team to be truly those COVID warriors, as you said, to be those, frontline warriors, was perhaps the most difficult part. Ensuring that we got the right PPEs, because that was still a big challenge at that time. Getting the right PPEs to make sure that our team is well protected. And then, when a couple of our team members volunteered, then it became a chain reaction. And multiple people just followed and said, we would The best part, Dr. Nene, is that when there was a lockdown announced and we were given this opportunity to test, more than 90% of our organization, and we have over 1,000 people that work with us, put their hand up and said,
Mm.
we want to contribute and we want to make a difference. That perhaps was the most amazing feeling that I got, that everybody in the team said, we want to be part of this, we want to contribute, we want to help. So I guess nothing connects people better than the sense of purpose and the sense of making a difference. And that's what's happened to us over the last 15 months, where almost 30% of our team has had the infection themselves.
Wow.
So that's one, yeah, that's a large number of people who actually got infected. Thankfully, every one of them has recovered and is back to work. There's not a single one who, after getting infected, said, no, I don't want to come back to work. So we've been lucky that we have a great team. I think the leadership played a big role of, being with the team on the ground. And as you said, we created a war room concept that we had all hands on deck. We had all team members coming onto a virtual war room, so to say, on Zoom. And because there were so many changes in regulations at that time, sometimes we had to have 2 meetings in a day because what we decided in the morning had to be changed in the evening. And that's how it was actually a war room concept that our COO designed. And that's how we were able to bring everybody together onto a common platform. And we continue to do that.
That's incredible. And we saw a lot of this taking place, not only in India, but obviously worldwide in the US. I talked to a lot of my colleagues, and honestly, being caught off guard is an understatement, because I think the whole world did not anticipate this. We were sorely ill prepared. Now, the real question then is, from the first wave coming to the second wave, I don't think anyone saw it coming necessarily in India. And it's been much worse, in my estimation, because it's not spared anyone. What's your anticipation? I know that the time to do a test went up significantly because there were so many tests done. But what is your anticipation? Did things change? Did it become easier come a year later in March versus a year before? Certainly the reagents and all the other tests were available, but the manpower and all that still needed to be scaled. So how did you deal with that? And what was your experience with that?
Sure. That's a great question. As you said in your question, that the biggest challenge for us was, or for any diagnostic player today, is being able to predict. I guess none of us has a crystal ball where we can gaze into the future and predict what the demand will be. So we don't know what the demand will be. And we have to be able to be agile to provide the supply side despite not knowing what the demand is. So I'll give you an example of what happened over the last 15 months, that when we started, we were able to do maybe a few hundred tests, up to 200 tests. And we predicted that this number might go up to 2,000 tests a day. That's the kind of capacity which we could build. And when we reached 2,000, we felt that we need to ramp up the capacity to maybe look at 4,000. Eventually, we could peak at around 5,000 tests a day,
And
and
is
we
it
were
all
able to
over
manage
India
that.
or just in Mumbai?
No, so we have our central lab in Mumbai, but on the fly, we set up another PCR lab in Pune because we realized that we needed to have, decentralized infrastructure as well, because getting samples from Pune and turnaround time was getting impacted. So we set up a lab on the fly in Pune as well. So combined, we could do a test of about 5,000 RTPCR tests a day, and we felt, I guess, that was a good enough capacity, to be able to meet the demand. And we were able to do that to a large extent, where up to December, the numbers were rising.
Absolutely.
In January, it's sort of tapering down towards end of January, and in February it actually came down significantly in this year. So what we did is we sort of downgraded the capacity, and we thought, the vaccinations have started, things are looking better, infection numbers are coming down. The infections are maybe a few hundred in Mumbai. So let's maybe downgrade the capacity and try and focus on other areas. Little did we know that in March, towards the end of March, when we were all hit with the second wave, there were times when we had over 12 to 13,000 test requests a day.
That's crazy.
And there was one time around the second week of April where not just us, but most large labs had to stop collecting samples because there was such a huge backlog of samples that we could not manage with the demand that was in front of us. After that, what we did is we realized that maybe this is something very uncertain. So we needed to increase testing capacity from 6 to 7,000. We actually broke down our corporate office because it's in the adjacent floor of our PCR lab, and we extended our PCR lab into our corporate office. So
Amazing.
today we don't have a corporate office, and that's why I'm working from home or from the other labs, because our PCR lab now has the capacity to do approximately 15,000 tests a day.
Mm.
But as we ramped up capacity because of the lockdown and whatever COVID appropriate behavior that people were able to follow, the numbers have again started coming down. So today we are doing about maybe 3 to 4,000 tests a day, but we do have the capacity of doing close to 15,000 tests. And as you said, should we anticipate a third wave? Very difficult to say today. If we are able to follow COVID appropriate behavior as we have been able to do in the last maybe 4 weeks,
Mhm.
and I hope so we can do that, then perhaps we can avoid. If vaccinations are rolled out at a much faster pace than they are today, perhaps we can avoid the third wave. But there will be still a significant percentage of the population that will still be vulnerable. The younger population, the people below the age of 18 who are not yet
Yep.
accessible for vaccinations.
Yep.
So, and India, as we all know, has a very large youth population. So in anticipation of perhaps maybe a third wave, we've just kept our capacity at 15,000 tests a day. And we will wait and watch and see that in case if there is a need, at least we have the infrastructure to be able to meet that demand. And that's how it's sort of gone up and down over the last 15 months for us.
So let's put that in perspective. At one point, we had over 4 lakh positive tests in India a day,
Yes,
right?
yes,
And you're doing about 15,000 of those. So you can imagine, how everyone all across India, as diagnostic labs go, had to scale. The second thing is, and a very good point you made, that while we're tapering, right, I would say there's no significant move on consistent vaccination. And until we ramp that up, I've seen less than 20%, less than 15% of the entire population has
yes.
had vaccinations. So the risk of a third wave, if we don't modulate our activities and maintain this kind of radio silence, if you want to call it, lockdown, if you want to call it,
Right.
going to be an issue. And I think people did get comfortable. I've talked about this on different videos because the numbers were so low in February. I think the points you brought up were absolutely right, that we thought we had missed the worst of it, and then the variants came in. Now, walk me through this. Let's talk a little bit about the tests, right? When do they become positive? So, a person comes in with the typical symptoms of cough, cold, fever, um, sometimes nausea, vomiting, diarrhea, malaise, chills, whatnot.
Right.
The recommendation of the GP or the FP or even us is that right now, don't think it's going to be the flu. Don't think it's going to be one of the many virals that Indians get. Always check. What test do we do at that point? And what is the best?
So, so I think things have evolved in the right direction over the last 15 months. When we started last year in March, there was only one test available. That was the RTPCR test. Of course, now we have the rapid antigen test, we have the antibody test, and we also have a rapid PCR test. So now we have four options, and let me explain what these options are.
Perfect.
The gold standard is still the RT-PCR test, which is the test which actually detects the presence of the virus. So it picks up the genetic code of the virus. So it identifies the presence of the virus either in your nose or in your mouth. And that's where the swab is taken from. And it picks up the genetic code of the virus. That is the gold standard test. There are limitations to this test because of the various steps involved. So uh, the way in which the sample is collected, the quality of the tube.
Done because we've read that the mid turbinates is where this is very prominent, and,
Yes,
and the nasopharyngeal area is really where the highest well, we'll talk about sensitivity and specificity, but that's the
right.
highest yield. So how should they be doing it when they come in? Because everyone's going to ask.
No, so there, I mean, so we have our team that has been trained on this extensively, that you take the swab and you push it up to a point where you get resistance, and that's where you collect the sample, and that's the best yield at that point of time. So if you don't push the swab deep enough, you may not get the best yield. And that's where the variability comes. Also, it depends on how much virus is, what's the viral load at different times. The viral load changes within the individual, the type of tube in which the sample is transported, the way the tube is transported, the actual transport conditions. The kits that are used in the lab have different sensitivities. So overall, the sensitivity of an RT-PCR is about 70%. That means that 70% of times the test will come positive, but there are 30% of times
Right.
where it could come false negative, that even if you do have the symptoms, but the test may come negative because of these variabilities. And we have seen on repeat testing, maybe after 24 or 48 hours, many of those cases that continue to show the symptoms when retested have actually come out to be positive.
And is that a function of the disease? Because I'll put up a diagram showing when the viral load goes, but from what I understand, at 5 days, the typical patient will have symptoms, but you'll be contagious for about a day and a half before that, and you
That's true.
should have enough mRNA that it's detectable. The other point I was going to bring out is when we talk about RT-PCR, the technical term is reverse transcriptase polymerase chain reaction, but what it does is amplifies a small amount of RNA. What does it mean? That there's a threshold, then there's a
Sure,
C value if it's good lab, and it'll tell you how much viral load you actually have. So tell me about that.
sure. So exactly as you said, that the technology itself amplifies the RNA or the genetic code of the virus. And CT or cutoff threshold is the minimum level of replications that are required for the virus to be detected in this technology. So the lower the number of replications or the cutoffs
Yeah.
that you need, higher is the viral load. So it's inversely proportional. So if you have a low CT value, it means you need less number of rotations to reach that threshold. So your CT value will be low if your viral load is high, and exactly the opposite. If you have a low viral load, your CT value will be
Would
high.
that correlate also to your infectiousness? I would imagine.
No, no. So actually, it correlates to just the viral load, and I think that's where the misnomer is, that
Okay.
CT values sometimes are taken as a measure of severity of disease,
Ah, okay.
and that it should not be.
Okay.
That I have seen multiple cases where a CT value of 29 remains symptomatic much longer than a CT value of 20.
So they haven't
Uh,
correlated one to the other because it's
so it's just the viral load, but I guess the immunity of the individual also plays a role. So it's basically telling us the viral load of the individual, but not as a measure of severity of disease.
okay. That's great. That clarifies that nicely. And then you talked about sensitivity and specificity. Sensitivity, as I understand it, is true positives, and
Yes,
specificity is true negatives.
right.
On on a screening test, which one do you want typically?
So you would want a test that will give you more of a false positive, so you don't miss out on the negatives. That's the idea, that if you get a false positive, you can still do something about it. But if you get a false negative, you are missing out on, and that person could still be infective and spread. So it's okay to get a little bit of false positivity, but you don't want to miss. But unfortunately, in this test, you do get false negatives because of the limitation of the technology. So it's a little challenging for clinicians and for patients, that when they have the symptoms and the test comes negative, they ask, are we truly negative? So then in those cases, we ask them, please repeat the test after 24 or 48 hours.
And so that might be related to where they are in the disease course and how much of a viral load they have on board.
Absolutely.
And so they might be symptomatic, but they may not have enough, or their immune system is blocking it. And then, you talked about a few other tests that are there, the rapids,
Yes,
antigen. So tell me about antigens and antibodies. You're the expert on it, obviously.
sure, sure. So similar to the RT-PCR test, which detects the presence of the genetic code, the rapid antigen test is also, it detects the antigenic material of the virus. It's a rapid test, it's a small car test, but the sample is similar to a swab, where you do a swab test and you have a kit that can give you a positive or negative within 30 minutes. It's a great point of care test where people are unable to come to a lab to give a sample, or where there is no access to good healthcare, but the sensitivity is maybe half as sensitive as an RT-PCR test. So if you are truly positive, you will still get picked up. But if you are weak positive, you will get a higher chance of getting a false negative in a rapid antigen test.
So in a
So
rapid
rapid antigen test is
specificity,
more like a mass screening test, or when you need to have the result within 30 minutes. So for example, if somebody is really sick and they go to an emergency room of the hospital, and they can't wait to decide, and if you have to triage, if you have to decide, should we or should we not admit, is it COVID or is it not COVID, that's perhaps a great application for doing a rapid antigen test. And if it comes positive, you know exactly what to do immediately at that point of time. So I think a rapid antigen test has its applications in remote locations, in point of care situations, in an emergency. Somebody comes with a surgery and they need to get immediate surgery, or the trauma case, then you can't wait for an RT-PCR.
sure.
Of course, now there is a rapid RT-PCR available, which is also called a point of care RT-PCR. So there are 2 or 3 manufacturers globally, one in India, of course, there's a company from Goa, MolBio, then Abbott is the other big company globally, where you can do a rapid PCR test and it can still give you the result within 30 minutes.
Very interesting.
So those are also available now.
So just to clarify that, if you do a RT-PCR, it's going to have a very high sensitivity at the expense of specificity. So that means you're true positive. If it says you're positive, you definitely are positive, or there's a high
Yes,
likelihood.
yes.
Whereas if it says you're negative, right, then you don't know for sure.
Yeah, so that's high specificity. That's high specificity, that if it is true positive, it's high specificity, but you will get some false negative. So the sensitivity is only 70%, but specificity is very high.
Okay, fair enough. And then you talked about so there was one thing I wanted to clarify, that when you talk about antigens, specifically what we're referring to are cell surface markers, which
Yes.
the body can see. And this is the interesting thing about COVID, that prior to last year, this was a novel coronavirus where our body had not seen those particular cell surface markers, and hence we weren't able to form the immune response. Is that about right?
Absolutely, absolutely. But there is a lot of overlap, and that's where perhaps in India we felt initially, where India was maybe a little more immune to the rest of the world
That's interesting.
because of the number of viral infections Indians are generally exposed to. So there was some cross immunity that was there, but that myth got completely thrown out of the window in the second wave. When
Absolutely.
so I guess that myth only worked up to a point, but I think the reality hit home in the second wave when the variants just completely took toll of the entire population.
And so let's talk about variants. What was your take on this? I mean, I've read quite a bit on that it's not just a double mutation, it can be many more than that. But the
Yes,
key mutations made it much more contagious, and in some cases, much more lethal.
virulent.
Yeah, and so what I saw in the second wave, and I'm sure you saw the same, was that we were encountering many more people with the disease. Is that true? And also the
Yes.
age groups have changed.
So I guess as the virus uh, moves from person to person, the more it transmits, more is the opportunity for the virus to mutate or change its structure. Now, many times the mutations goes against the virus. It sort of makes the virus weaker. Unfortunately for us, the virus has become stronger. And what happens in India, as you said, is that there were multiple mutations that happened together. In the UK or in Brazil or in South Africa, they had a single significant mutation. But in India, I think there were 2 large mutations that came in together. And that's what made the mutation even more deadly, as we saw. And very correctly, as you said, that Why are we seeing more people within one household getting infected? Because of this, that the virus is easily able to spread from one to the other. So infectivity and even the virulence, the severity of disease is much more.
Absolutely.
And and the and the data is still out there, but we are finding that perhaps vaccination to be maybe less effective against the variants, that we expect vaccination to prevent severe disease and death, but we have seen a few hundred cases of people who have succumbed to the COVID infection despite having taken 2 doses of the vaccine. And that's definitely a concern for all of us, that if these breakthrough infections, as they are called, that people who have taken the vaccine and still get infected, but if they have a mild disease, it's okay. But if they have severe disease, or they have a death after taking the vaccine, that is definitely a cause of concern.
So that brings up an interesting point. And to me, with the breakthroughs, there's either one of two potential possibilities. The one is the fact that you may not have generated an antibody response, which is one of the questions I want to ask you, that when should you be testing for neutralizing antibody after getting vaccination? The second point is that perhaps the structure and maybe the NCOR protein or any of the surface antigens which we were priming against. And from what I understand, the different vaccines, Pfizer, Moderna, are a new mRNA class, but even the chimpanzee adenovirus vector vaccines use the same N surface protein to basically give people immunity. Now the
Right.
question is, or rather the thought would be that if the virus mutates and just by natural selection, it will survive if it can get to more hosts who don't have immunity. Then what one would question is whether these people who are quote unquote, having the vaccine and still getting the disease, maybe they're seeing a different disease altogether, meaning that the cell surface antigens are not the same. So what do you think in that? And when do you
Sure,
order an antibody, like a neutral
sure,
antibody?
sure. So let me step back and maybe just give a little input on antibodies. So antibody is a blood test, unlike the RT-PCR test or the rapid antigen test, which is a nasal swab test. The antibody test is a blood test, and it picks up different types of antibodies. So there is IgG, IgM, IgA, but most of the kits have what we call as total antibodies. They collate all the antibodies and make it into a total antibody kit. And typically there are two types of antibodies that we test for. One is the antibody test that we do to check if you were exposed to the COVID infection. So people who have been exposed and have recovered from it will fight and will have an antibody response, and they will produce antibodies against the infection, a natural infection. And the second is, as you just correctly said, the neutralizing antibodies that are produced after vaccination. So it's very important when you order an antibody test, you must let people know that is it for checking whether I was exposed to the virus, whether I had an infection or not, or whether I am doing a test post vaccination. So if you do a test which is, if you are doing the test which is post exposure for someone who's been vaccinated, it may come falsely negative. So I've taken the vaccine, but I've never been exposed to the virus. But if I do the test which is for post exposure, it'll actually come negative. So it's very important that I tell them that I want to do the test, the neutralizing antibody test, post vaccination or post exposure. That's the difference. And more often than not, I would say in 95% or maybe more, I don't have the exact data with me, but I know a very, very high percentage of people, when tested for neutralizing antibodies after the vaccination, have shown a positive response.
Um,
The ideal time is 2 weeks after you take the second dose. That
okay.
would be the best time to test for neutralizing. And in our data, almost everyone has produced antibodies, but we are seeing people, despite producing antibodies, still getting infected.
So here's a question. How much is enough? I mean, what's your reference range? I know zero point 0.8, I actually did them after my second dose, and zero point 0.8 is your positive threshold, and mine were greater than 250, which you know as
Right.
well as I do.
Yes.
Now, the real question is, in vitro as well as in vivo, the observational studies are going to show you that these people who had it, of the 180 cases, you know, I don't know, whatever it is for AstraZeneca or for Covishield, but that 74%, give or take, were protected depending on when you got your second dose, versus, you know, a mRNA vaccine like Moderna or Pfizer, which was 95%, meaning the majority of the placebo guys are the ones who got the disease, whereas the vaccination. But in your estimation, I mean, is there a clear-cut register of when, just because you got the antibodies, are you safe? I would say yes. But if
Yes.
I have 95 versus 250, does that matter?
So the first type of antibody test that was available is the qualitative, which just tells you whether you have it or you don't have it. But the ones which are neutralizing or the post-vaccination are quantitative, and that's why you get the value greater than 250. But as you asked the question, how much is enough? That's a big question mark today. How much is enough? And how long will this last? How
Yes.
long will the immunity last? So it's still up there. I think it's just early days for us. What we have seen is people who have recovered from a COVID infection generally have antibodies in their bloodstream for at least 6 months
Okay.
on an average. And we have seen people in my own team who have had antibodies for at least a year after being infected. So, you know, we had someone who was infected last year in May, and he still has antibodies. He's not taken the vaccine, he still has antibodies. So 6 months is generally considered a safe time where you will have protective antibodies. And the important thing is, what is the objective of vaccination? The objective of vaccination is to prevent severe disease and death. The
Absolutely.
objective of vaccination is not to prevent getting infected. So you
Yeah.
still can get infected. And that's why it's very important that even after taking the vaccination, you continue to wear the mask, you continue to have social distancing, you continue to stay at home if you can. The COVID appropriate behavior needs to continue even after vaccination. And as you said earlier, I think we just dropped our guard after we got vaccinated in January and February. As we say, you know, in boxing, you have your guard up here. We
Yeah.
just lowered our guard. We just became casual. And that's why we got hit.
I might have dialed that back a little bit, and not emboldened people, and said the same thing that you did, that look, and I would take it one step further, even in India, that until everyone is immunized, no one is immunized, in a sense,
Absolutely.
right?
That's a great statement to make. Absolutely.
And
That's a
so
wonderful statement.
kind of take our own guard up, not down, and, you know, keep this. And one other point you said is an important one, that this prevents you from dying from it. It prevents you from, right now, 15 to 20, 10 to 15% will get hospitalized at most, right? The remaining will be able to tolerate the mild to moderate COVID with the current disease.
Right.
In those 10% that get sick, depending on your age and your comorbidities, less than probably 1.5% in India will actually succumb to it, right? Depending on all of that. So the real thing it's doing, like you said, is that it's preventing that type of carnage. It does not, however, prevent the mild to moderate. And we don't know for sure that it will prevent you from spreading, although the Israel data is very compelling to suggest that the infectivity rate, the virality, which you described, is low. Is that true?
Absolutely. So I would I would just add to this that I think the Pfizer and the Moderna vaccines probably are a little more effective in preventing transmission as compared to the AstraZeneca or the Covaxin
Variant?
vaccines are. I think those vaccines perhaps are able to prevent transmission a little more effectively.
But I think these are great points. Let's turn a little bit to your personal journey as a physician, as a influencer, and tell me a little bit about what you think would be ideal and where you see healthcare heading in India.
Today, I tell people that the five most common alphabets known to people on the planet are RTPCR, unfortunately. And the reason I say this is because I have been in the diagnostics industry for close to 30 years, but I've never seen the focus that the diagnostic industry needs to get as much as it has today. So how testing has played such a critical role in detecting and controlling this pandemic. I think diagnostics, we all know, impact 70% of medical decision making at maybe less than 10% of the overall cost to the patient. But it is only during COVID that we have seen the true impact of diagnostics and how it can make a difference in medical outcomes. So for me, the next 10 years is truly the era of where healthcare will just completely transform itself. Words like comorbidities have become, commonplace terms for people to know what is the meaning of the word comorbidity. People know the importance of maintaining good health. They know that if I have diabetes, or if I have hypertension, or if I'm overweight, or I have a lung condition, I'm more prone than someone who is not. So I think the ability to look after yourself proactively, maintain, stay away from lifestyle disorders, be more proactive in your own health assessment. I think the way in which healthcare will be consumed is definitely going to change for the better. And I think diagnostics is going to play a pivotal role. So, I feel extremely proud and privileged to have been part of the diagnostics industry, and look forward, to using technologies like PCR and genomic testing in making a difference, because we know that testing is going to get personalized. So what works for you may not work for me.
Sure.
And how genetic testing will actually personalize health outcomes for individuals. And I'm very, very bullish that I think COVID has just pushed people in the right direction. I mean, it's sad that we needed something like COVID to change the thinking, but I think people will be pushed in the right direction for the right reasons. And I think healthcare outcomes will just significantly improve over the next 10 years.
So in a word, awareness has kind of come to a higher height in
Much better.
the
Absolutely.
next question I would ask you is the future and where we're heading, because, going from ELISAs and antibody tests to PCRs and now to tests on a chip, right? Where you can quickly change up your routine, and then going to mobile testing. Because I think in India, when you look at the equation, it's a little different than the rest of the world, that 70% of our people live in the rural areas, 30% live in the metros, and many people don't have the infrastructure. And so how do we get that to them? Because only then can we, improve lifespans and lifestyles. So what are your thoughts on that?
No, absolutely. I think in India, because of the kind of the vast divide between urban and rural populations, the fact that we have 70% of the population which is rural, but majority of the healthcare infrastructure is urban. This gap between demand and supply is a huge challenge today. And I think one thing which has happened with COVID is the uptake of digitization. And I think telemedicine, teleradiology, telepathology is here to make a big difference to people who may not have direct access at this point of time. But with digital interface, I think we will be able to penetrate those parts of the country which did not have access to quality healthcare. And similarly, I think diagnostics will also move where we will see a lot more. I would think about 25% of testing over the next decade will become point of care, where you would be able to see good quality point of care devices, as you said, lab on a chip. Such point of care devices, we have companies in India that are already working on this kind of technology. So I think point of care testing will be able to take at least the essential testing to the rural population. So I think that's the whole digital transformation, and point of care testing will definitely bridge this gap between urban and rural. And I think, as we spoke earlier about the awareness quotient, as the awareness goes up, the consumption of healthcare will also happen proactively. The idea is that we want to make sure that we pick up conditions at a stage where it is detected early, where it can be prevented or it can be reversed, so that the burden on inpatient becomes much less. We treat in the OPD what we can, we manage in the OPD what we can, we pick up conditions earlier, so that the burden on inpatient becomes that much less. We know that the number of hospital beds or the number of doctors to the total population there's a big gap there. So we need to step in. I think diagnostics overall and health education can play a big role in reducing this burden on inpatients so that we manage more in the outpatient. I think that's going to be the trend going forward.
I think those are really good points in that you're really moving the pendulum back from acute care to prevention, early recognition, and early treatment. And in
Yes,
doing that, India doesn't become a natural history study, which we read in the books. Instead, we
absolutely.
are preemptively striking and getting in when we need to, and making people aware and giving them access to, you know, world-class evidence-based medicine, which I think has been lacking in many regards. And I think the pandemic, in some ways, with the telemedicine technology and everything you've said, has moved it in the right direction. And also with your efforts and everyone else's, the real heroes in this, I would say, this has been there. Now, let's move to another topic, which is a little
I'll
more.
just add one point you just mentioned. So if you don't mind me adding 2 points,
Absolutely.
I really like the point you mentioned about, where because of the vastness of the population and there is so much of data that we generate,
Yes.
evidence-based medicine, as you said, um, we just have to use the data that is there with us, and the kind of evidence that data will provide will be better than any other data anybody else could provide, purely because of the vastness of the data that we have. And we have done that in our own organization, where we've been able to predict uh, infective, urinary tract infections, what's the local prevalence of drug resistance, and how can we help doctors understand that just by doing analysis of our own of our own data today. Now there is the National Digital Health Mission, which is going to standardize this data across the country, and I think that's going to be pivotal in making a significant change in health outcomes in the country. Because today everyone has data which is not uniform, which is not structured. But if you can get uniform and structured data across the country on the same platform, just the wealth of knowledge and information that we can get
Absolutely.
from that will be path breaking, will be a game changer, according to me. So I agree with you completely that the data analysis will make a big difference in evidence-based medicine. That's going to be pivotal in the way in which India changes its health outcomes.
I agree with you 110%, because here's the truth. India's always been a volume game. It means we have to provide things at a much lower cost in higher volumes to take care of our populations. But the flip side of that is, if we can anonymize the data, and we work with the plumbing layer of the national healthcare mission. We actually, I do personally, and I know what you're talking about. And if you can think about it as evidence-based medicine, the statistical power which you will derive and the
Yes,
conclusions you can draw in an anonymized, privacy protected fashion
absolutely.
are jaw-dropping, because India
Yes,
can become a leader in the world by telling people what are the best practices based on data. And we can also create predictive AI logic, which will
absolutely.
tell you the right way. And this is what you're talking about, and 100% agree. So that's a beautiful point you just brought out. So let's move on now to the second wave. And, I think we both said it, that this one has been personal, and that no one has been spared. And I don't think in your case that's the any different, and even more so uh, because you had it in your family. Can you tell us a little bit about that?
I can't think of a single Zoom call today or a single meeting where the first 10 minutes is spent on sympathizing or empathizing with someone who has personally gone through a tragedy.
Yep.
So, as you correctly said, that second wave has hit home up close and personal. Almost everyone that I know on a personal level, in some way or the other, has been affected directly. Uh, Early April, both my parents tested COVID positive.
Mhm.
My mother has been a patient of lung fibrosis for many years, so she was anyways having, weak constitution, and because she was practically bedridden, she was unable to get access to vaccination. My father, who's 85, but took both doses of vaccination. Surprisingly, none of us at home who used to move out from the house tested positive, but only my two parents, who were always at home, both of them tested positive.
So sorry.
And then because of their age and because of the comorbidities that they had, uh, and my mother's oxygen saturation just dropped to 82. Um, we had to rush her to an ICU. We had to shift my father to a different hospital because getting hospital beds at that time was very difficult. But thanks to the local authorities, thanks to friends, we were able to get both of them hospitalized. But because of my mother's underlying condition, within 72 hours of being detected, and despite the best treatment at the hospital, she could not make it, and she succumbed to the virus on 11th of April. At that time, my father was still in a different hospital, being treated separately. Fortunately, because he had taken both doses of the vaccine, his disease was much milder. So he's home, he's healthy. Um so in my case, we lost our mother, but I know so many other people who've lost, a parent, a child, a younger sibling. The age group, is from 20 to 50. The number of people, in our team, we have seen immediate, a sister being lost, a mother being lost. So I think there is just so much of tragedy that we have seen everywhere. And that's perhaps the biggest or the worst impact of the second wave, is that it's hit home, up close and personal. And I don't think anyone is spared. It does not look at gender, it does not look at caste, it does not look at socioeconomic status. Um, it's just it's just hit home very close. So, but I can share my own experience that because my father did get vaccinated, his disease was much milder.
Yeah.
So that's the message that I want to share with people, is that please, please, please get vaccinated.
I think you said it beautifully because more than anything, and first off, please accept our condolences because
Thank you.
losing a mother is catastrophic, and
Yes.
losing anyone in your family, which I think every single one of us has family members who've succumbed to this in the second wave. And it's really been heartbreaking, because you wonder, and the other part of it is, as a physician, you feel a little bit invulnerable, and not even us who know our science, know our medicine, know the ability can prevent this. We're humbled. And I think the only way to do that, as you pointed out, is to vaccinate everyone as fast as we can and take the precautions before and after until everyone are. And so if we can put out one message today in this talk, that would be it, and carry it everywhere, that
Yes.
we stand before you saying, look, we have obvious evidence, anecdotal as well as good scientific evidence from all of the studies. And we're telling you now from our hearts that you need to vaccinate
Yes.
everyone in your family, and then mask until everyone's vaccinated, and only then will we get through this. So I really appreciate you sharing that, and I know it's difficult and not an easy thing, but I think you have spoken to a lot of us who are in similar positions, grieving and going through the different stages and trying to figure out what we can do different, this and that. And honestly, in many cases like this one, there's nothing you can do different. I think this is a disease without a vaccination that everyone is going to be at risk for.
No,
So
and the guilt that I go through, is that, as an organization, as a doctor, you helped so many people. We helped millions of families,
yes,
but I was not able to protect my own parents, from this illness, and that sort of continues to, play on my mind every day. That, I try to keep them safe as much as possible, uh, but I guess so it just shows that we all are human. There's, despite our best efforts, there's some things which are just beyond our control sometimes.
and I think one thing to add in talking to a number of physicians, not only is it the helplessness or the feeling of helplessness and guilt, but even with our patients, these patients often succumb alone, because this
Yes,
is one illness where the family can't be with them, as
absolutely.
and the doctor taking care of them becomes a family member and has to see the whole process. So the level of PTSD and grief that we're, as a nation, as a world.
Oh yes, oh yes. The mental trauma is just equal to none. I spoke to a colleague of mine the other day. She was COVID positive, and while she was in hospital, her father passed away. But her family could not tell her because she was recovering herself. She got to know about her father's passing 10 days after she recovered, and she
Wow.
got to know that her mother had to cremate her father all by herself.
Oh no.
Now, these are these are heartbreaking stories. Last year, I lost a dear friend. At that time, they were not allowing the families, to do the last rites. So the municipal authorities, cremated my friend uh, at a crematorium. So we could not even see him before he left. His family, his parents could not even see him. So the heartbreaking stories that we hear every day is just
And these are
uh,
the fundamental features of a culture and of mankind, that we
yes,
grieve for our people
yes,
who have passed, and we can't even do that right now. And so
absolutely.
here's to hoping that we can make this through with the right measures, which you're doing. I want to do a rapid fire now, if I may,
Sure, sure.
and then we'll conclude this. But this is a fast one, which is going to be 30 seconds, a minute or so, and it'll educate people on, how to behave. So uh, I'll throw these stuff out. We can make it a khichdi afterwards in post, so don't worry about that. But
Sure.
I've got a cough, cold, fever. What should I get, an RT-PCR or an antibody?
RTPCR.
Great. And at what point will that RT-PCR turn positive? 5 days, 10 days, or 15 days?
The day you have the symptoms.
Great. And when should I get an antibody after vaccination?
2 weeks after your second dose.
Perfect. And do I need to get another RT-PCR after I've recovered from COVID?
No.
Okay, great. What point are you immune to this? Does the first vaccination help you enough, or is it the second vaccination?
We've seen many people develop good antibody response even after the first dose. Uh, but I think I would recommend that people take both doses. There are some recommendations where they say that if you got an infection after the first dose, you may want to delay the second dose.
Okay. And after I've already had COVID, how much do I have to do? Do I need to take it after 3 months, 6 months, or 12 months?
That's a great question. And the general response is 4 weeks after you have recovered or 6 weeks after you've tested. But now, because of vaccine shortage, you could wait even up to 6 months. So I guess anytime 3 to 6 months after you have recovered is a good time to take your first dose.
Okay. This is perfect. I hope you enjoyed that. And
Absolutely, absolutely. I can just add, my three big messages to people, is don't drop your guard, be vigilant, wear a mask, and get vaccinated.
perfect. If you like what you're hearing, hit the like button. Want to share it with all your friends, that would be great. And hit the subscribe button if you want to see more episodes from this channel. Hit the bell icon so that you can be alerted to the next one that we come up with. Thank you for joining us as always. It's always been a pleasure, and I look forward to seeing you again.